All right, great. So this will be just a very practical, what have we evolved to in the radical cystectomy patient? Again, no disclosure, sadly. All right, so we're going to briefly talk about ERAS. You know, ERAS is like the hot thing everywhere, whether it's colorectal surgery, general surgery, Urogyn, GYN, ONC. Everybody's trying to get everybody out of the hospital as fast as possible, understandably. Give them the appropriate treatments. And we're trying everything, right? IV Tylenol, I mean, tap blocks, everything you can think of in the operating room to get people out of the hospital. So I'm going to talk to you about kind of what I've evolved to since really kind of embarking in radical cystectomy, and particularly robotic radical cystectomy. And just to give you some background on that, I trained in open cystectomy at University of Kansas, at KU, and then I went and did a minimally invasive fellowship and urinary or urethral reconstructive at Mayo Clinic in Arizona, and then kind of moved on to the robot. I'm going to tell you that originally I hated the robot with a passion, and the reason was, which is hard for a lot of people to believe, was that I was trained as a laparoscopist, and I didn't need a robot to help me do anything. And then, like so often is the case for many surgeons, is once you use the machine, you get kind of seduced by it because it makes everything easier if you're able to use it in a particular case. And then, you know, we've had an evolution of different pathways. And my enthusiasm for various different things has waxed and waned, whether it's intracorporeal diversions, whether it's, you know, getting people out of the hospital. And I've really come to some kind of observations that we'll talk about here. So again, ERAS is the fad. What are some things that we've realized over the last 10 or 15 years? Well, it's that, one, you don't really need a bowel prep. And I remember in my residency, especially at the VA, if a patient showed up and had not done their full Nichols prep and taken, you know, a full bottle of Go Lightly, we would cancel the operation, just flat out cancel. You were convinced that if they missed that dose of neomycin or emycin, that they were going to get an infection. And it was interesting because it goes to show you, it's kind of like the Will Rogers quote that Mike put up, experience really is everything. I was at a course, I was junior faculty at Tulane, and my brain is not working, Urs Studer was giving a course, and I took a postgraduate course in taking care of the cystectomy patient, particularly the neobladder patient. And all of the things he said in 2005 were very current today, which was remarkable. For example, I remember when he said, well, I don't bowel prep anybody. This is small bowel. You shouldn't have to worry about infection. And I was like appalled. I couldn't even imagine that. You know, you're going to be opening the intestines, and we all see the succus coming out, and it goes into the wound. How could you possibly do that? And it wasn't until I got to Mayo and I was putting on a case where the patient was also going to get an end colostomy, and I asked one of our colorectal surgeons, I said, hey, what kind of prep do you want, since, you know, you're dealing with the dirty part of the body? And he said, well, we're not going to bowel prep. And I said, well, what are you talking about? You're dealing with the colon. You must bowel prep. And he said, well, he directed me to a randomized trial that looked at colorectal patients, colon cases, about as dirty as it gets, and there was no significant difference in the development of abscess if they'd bowel prepped or not. There were some other little subtle things, just like any other randomized trial, you can break it down. But the take-home was we were probably overutilizing bowel prep. And so then I kind of did it step by step, got rid of the Nichols prep. Then, okay, now we'll do just one bottle of mag citrate. Okay, clears the day before or maybe for 2 days. Finally, now it's just NPO after midnight. They can have whatever they want to eat the day before. And it's hard to imagine that, but it really makes a difference. Why does it make a difference? A lot of us in the operating room have anesthesiologists. Are there any anesthesiologists in the room? Good. They will sometimes overload them with volume because they're trying to catch up for the bowel prep. And what ends up happening is you get overloaded patients post-operatively, which can be a real challenge to deal with. So when they come in without a bowel prep, you can express to them, look, you know, you don't need to worry about giving them 2 or 3 liters in the first 45 minutes of the operation because they're not dehydrated. They're just NPO after midnight. Narcotic avoidance, we're not the only ones doing this. Anesthesia is using a lot of IV Tylenol. We use Toradol like it's going out of style. It's something we use in just about every patient unless they have a significantly elevated creatinine or low GFR. And now pathways are really the next step, right? You know, how do you get these patients out of the hospital? Well, what are some considerations? Well, this is an unhealthy population. Furthermore, we use neoadjuvant chemo, and it's just generally all cisplatin-based. You can use some split-dose platinum when patients' GFR is under 60, between 50 and 60, but we beat these patients up, and they already are beat up when they come in with this advanced disease or significant disease and why you're doing a cystectomy. Furthermore, they have significant thromboembolic risk. Just getting the chemo increases their risk of blood clots. So all of these things are things that we have to be thinking about when we take these patients to the operating room. It makes the surgery a lot more challenging. So what do we find? Quite frequently, because and Alan can tell you, we marinate our patients in platinum prior to surgery, and they are almost all anemic as they come into the operating room. And this can be an issue. If you do the most bloodless operation, and it's a radical cystectomy, and their hemoglobin starts, pick a random number, let's say 10, they will, without a doubt, within 2 or 3 days, get down to 8 and maybe 7.5. With fluid shifts, fluid resuscitation, everything that goes on. Now, luckily, I'm assuming people here in the audience have noticed that hospitals are moving away from early transfusion. You know, remember we used to transfuse people when they were below 10 because we were worried about cardiac history. Now it was 8, and now we even let them get down to 7 before we transfuse them. So transfusion rates have gone down when you change your threshold. But I prefer if they have a hemoglobin of 11 or higher. So what do? Right when they finish with a medical oncologist, I see them, usually about a couple weeks before their last cycle, and I give them vitamin C and iron. And they get 500 milligrams of vitamin C tablet, and they take 650 of iron, and they take it at the same time to improve absorption. And this will help some of that anemia, because they've got, their bone marrow is a bit suppressed, but this will help you by the time you get them to the OR in about 4 or 5 weeks, and you might get them over that 11 or 12. Now, some of the patients who are getting dose-dense chemo might be getting some factors and things that are going to help them rebuild their bone marrow a lot faster. But these are some very important things, in my opinion, to help you avoid things that are going to keep them in the hospital. Nutritional status. Well, you could go on PubMed and find numerous studies that have looked at the nitrogen balance and the nutritional status of all these patients, and it sure would be great if I could put feeding tubes in everybody and give them, tube feeds, or put an IV in them and give them TPN for 4 weeks before surgery. But the reality is that these patients generally don't have that kind of time, and it's very rare that we have someone that we're able to do that in, because if they're that sick, you're probably not going to be taking them to the operating room because they're so comorbid. But nevertheless, what do? I educate them. We have a whole education program preoperatively where they learn about nutrition from a nutritionist, and we talk about supplementing them with protein. These, again, it's incremental benefit from all of these little things that we've found. This is one of the biggest ones. You can do a robot. You can use no narcotics. You can try everything you want. But if that patient is there and you're ready to discharge them on Saturday and their insurance doesn't have home health set up and your social worker isn't ready or they're not in the hospital, guess what? They're staying 2 extra days till they get to Monday. So what can you do? You can prevent this ahead of time by consulting social work, and at least at our institution, they get a visit with them, they run their insurance, they identify, okay, they're from out of town, they want to do the home health here, or they might want to go to a rehab center. All of this is arranged before they get admitted for their surgery. And that will help decrease some of those things that keep them hovering in the hospital, and then yet another complication occurs. Educating the patient, also super important, right? This is a complex thing. It's complex for us, let alone a lay person and people trying to figure out the bag and the tube so they get the stomal nurse visit. There's all this preparation that occurs the week before surgery, and you educate them. If I tell them, and they say, "Doctor, how long am I going to be in the hospital?" And I say, "Well, you'll be in the hospital 4 days." They'll be there about 5. If I tell them they'll be there 7 to 10 days, they're going to be there 10 days. Because that's what they heard, and that's what they tell their family member. And then you're ready to send them home, and they'll say, "Well, my wife's not ready to take care of me. You told me it was going to be 10 days. All of these little things that are completely different than anything clinical or medical that will play a significant role in getting them discharged. We talked about the bowel prep. Who will I bowel prep if it's a salvage cystectomy or someone who's had radiation for their prostate? And it's a real simple one. It's mag citrate, a bottle, the evening before surgery, and then in pre-op they get an enema. Because what you really want is you want the rectum clear of any gross fecal contamination should you have a rectal injury during surgery. Because, as you know, that's very hard to heal. Alvimipam. This has been the game changer, in my opinion, in the world of radical cystectomy. And I used to be able to demonstrate that a robot could get someone home several days faster than an open cystectomy. This darn drug has now gotten it to the point where the opens go home just about as fast as the robots. It's off by about a day, but it's significant. For those of you who don't know, this is a mu-opioid antagonist. It blocks the opioid receptor in the intestines and basically diminishes the impact that narcotics have on the gut. Now, I will say that the robot world pushed the open surgeons to this, right? They were comfortable in their world, and then they were threatened, in my opinion, by robotic cystectomy, and we've all converged to this attempt at getting patients out as soon as possible. And I think that's one of the very positive things about coming up with these pathways. It's a dose given to them in pre-op. It's taken twice a day, and it's roughly for about a week. There are a few exclusion criteria if they had some cardiac issues, or if they've been on narcotics for an extended period of time, they can't be on the drug. My colleagues up in Rochester, we haven't done this. I don't know, Mike or anybody else who does cystectomy here, if you all are using Amicar intravenously. They have a paper, they demonstrated decreased transfusion rate in their open series. It's something you can look at. There is appropriate dosing. It's ironic because I was always fearful that it would cause blood clots and PEs and DVTs, but apparently not, at least what they've demonstrated. So they use it in their practice. We're doing this whole practice convergence thing, but they don't use alvimapan. So, we're trying to figure out, what will add to decreasing hospital stay. Post-op, another thing, we used to have NG tubes in everybody. We've pretty much gone away from NG tubes in just about everything. Patients, that's one of the things they despised most. So we just don't put an NG in, and the ones that need it, you can put it in later, and they just seem to recover better. We have this whole thing where they have to sit in a chair the evening of surgery, or at least the following morning. They have to ambulate multiple times the first day after surgery. I keep them NPO, meaning just some ice chips at most and meds with SIP so they can take the alvimapan. Now, I have some colleagues that will do this whole 8 ounces of water every 8 hours. I tried that for a while. The problem I had was that the few patients that would have a problem with that, they'd kind of take 2 steps backwards and die, and they get all distended. What I found is that if they do alvimapan, they've had all the other things we've set up. Usually by day 2, post-operative day 2, they start to pass a little bit of gas. I'll give them liquids that night or in the morning of post-op day 3. And I don't do this whole liquids, soft, mechanical. It's they give diets to people who have gastric bypass surgery within 48 hours, and we're worried about our terminal ileum. So if they tolerate a liquid and they're not vomiting, they get a regular diet. Another thing to get them out of the hospital a lot faster. You're not waiting 24 hours for them to get a diet. And I hep lock their IV because I want to know if they're going to have a problem keeping hydrated right away. I don't want them to be discharged having had an IV running, and then they come back to the ER with failure to thrive. Antibiotics, that's another big thing now, right? We only do it for 24 hours. It's hard to imagine. We used to do the whole IV antibiotics for 3 days, 3 or 4 days, till they could tolerate oral. Then you get them on suppressive for 2 weeks till the stents came out. That's pretty much done. We talked about clears. I think drains and stents you can really use. I don't think that changes much. Most of the time, a stent stays in about 7 days, which always amazes me, right? For a pyeloplasty, we leave it in for 6 weeks. But when we put a piece of ureter into a small bowel, we take it out at a week. And drains just come out pretty quickly once there's no urine in there. They're going to have a significant lymph leak. Women will drain from their vagina, men through their urethra. That eventually stops. Fluid boluses nowadays very rarely needed. Our anesthesiologists run these people dry as can be. They run maybe a couple liters in the OR the entire time. It's changed the paradigm with how they manage them. Again, I told you about the discharge date. And then lastly, we wrote a paper looking at what would be some of the things we could identify as independent predictors of these readmissions to the ER, return visits to the ER and readmissions to the hospital for that failure to thrive picture, that patient that shows up, dehydrated, their creatinine's elevated, they're hyperkalemic, they look like death warmed over, they get readmitted, and they just get volume given to them, and then, they get better. So what we found was it's the people who are acidotic, and the people at risk are people with orthotopic neobladders, so continent diversions, patients over the age of 70 to 75, you found that they were at greater risk for readmission. And if their CO2 on their base MET on their panel was 21 or lower, really lower than 21, prior to discharge. And what we didn't do was we didn't intervene for that acidosis, even though they weren't symptomatic. So I'm pretty liberal with sodium bicarb. And by the way, that's something that Dr. Studer said back in 2005. Because he probably saw a lot of neobladders, because that's what he did, come back to the hospital with failure to thrive. Now, I do this thing where I'm not a believer. There were some people who have published out of USC where they send them home on IV fluids. I mean, to me, that's not going home from the hospital. You're basically sending them home to a rehab center or something like that. We do discharge them without fluids. What I do is I bring them back every 48 hours 2 times. So if they go home on day 4, day 5, they still have the stents in. They come back 2 days later. They get their stents out. I check labs. Look how they're doing. Then 2 days after that, check labs one more time. And usually if they've made it about 8 to 9 days, almost day 10 after surgery, and their labs look okay, their CO2 is fine, they're tolerating a diet, you can, not always, but for the most part, they're not going to get readmitted. Now, what can you do? You can also intervene early. If they're looking puny, but they're not sick enough to be readmitted, we send them to our outpatient intravenous infusion center, and they'll get a liter of fluid, and we'll recheck their labs the next day. But these are other ways that you can affect their risk of coming back to the hospital. I think the real question, which would be interesting to discuss here, is anticoagulation. You know, the hot thing now is perioperative, both pre and post coverage or prophylaxis chemically, right? We use Lovenox, or you can use sub-Q heparin perioperatively, but for the longest time, you discharge them from the hospital and they wouldn't be on it. And then what we found was people come back with DVTs 2 weeks, 3 weeks, 30 days later. And there are some people who will say, you know, our risk of bleeding is so low that they just send them home on 30 or 40 milligrams of Lovenox intramuscularly for 30 days post-op. Now, I have been doing that for patients who've had chemo. I don't have any data to show that it's all that great, and I'd love to. We've been trying to get a trial multi-institutional-wise to get it going, but the hard part is getting people to give it up. So when I ask them, I go, why not do this trial? They say, well, we send them home on 30 days anyways, and you know it's cheap now. Lovenox isn't expensive. Well, it's not very risky, so why would I not do that? Well, there are studies now that demonstrate no benefit also. So I think this is the unanswered question. There's probably some metabolomics that people are working on to see who's at risk in this patient population. So I hope that gave you some idea of how we manage these patients. I think hopefully it's a very practical thing, and you might find it beneficial in your practice. Thank you for your attention.